Welcome back to Decode Healthcare with Harshal. So if you were with us for part 6, you know we tackled the incredibly complex world of the shoulder. Well, today we're moving steadily down the arm to decode the CPT codes for the humerus and the elbow joint. We are diving into the 24,000 series, covering codes 23930 all the way through 24999. Grab your CPT books and let's get to coding.
Here's our roadmap for this CPT block: the humerus and elbow, anatomy and excision codes, sports injuries and repairs, fractures where location is everything, and finally, amputations and our outro.
All right, part 1, the humerus and elbow, defining the anatomy. Let's start by anchoring ourselves to the exact anatomy we're going to be coding today. The humerus is that single, long, really thick bone sitting directly between your shoulder joint and your elbow joint. So, in plain English, when we say humerus, we are talking exclusively about the upper arm.
And you know, this perfectly illustrates why understanding this specific bone is literally the key to unlocking this entire CPT code range. In medical coding, you simply can't code what you can't locate, right? The humerus is basically the structural foundation for your bicep and tricep muscles, and it forms the entire top half of that highly mobile elbow joint.
Moving on to part 2, anatomy and excision codes. This is all about removing cysts and tumors.
So now that we know exactly where the humerus is, let's talk about what happens when a surgeon actually has to remove something from it. For excision codes 24065 through 2455, precision in reading that operative report is just everything. You absolutely have to check the medical report to see the depth of the excision. Like, did the surgeon just scoop out a superficial cyst right under the skin? Subcutaneous? Or did they really have to dig deep into the subfascial or intramuscular tissue right up against the bone itself? Plus, as the CPT guidelines strictly dictate, if a soft tissue tumor is removed, you've got to measure the greatest diameter of the tumor and then add the narrowest margin required for complete excision. That total combined size, that is exactly what dictates your final code. All right, part 3, and this is a fun one: sports injuries and repairs. We're looking at codes 24300 through 24498. These codes are honestly some of the most frequently used in orthopedic clinics. But before you can code a repair, you actually have to know what's being repaired. There's a crucial anatomical difference here that trips up so many new coders. Ligaments are bone-to-bone connectors. Think of them like the mechanical hinges on a door, keeping that elbow joint nice and stable. Tendons, on the flip side, are muscle-to-bone connectors. They're more like pulley cables that actually do the work to lift and move the arm. Just keep that plain English in your head. Ligaments equal hinges, tendons equal cables. So let's apply this to some really common injuries. Take codes 24357 through 24359, for example. These cover epicondylitis repair. And hey, don't let that massive clinical word scare you off. Epicondylitis is literally just the fancy CPT terminology for fixing classic tennis elbow or golfer's elbow. When you're coding this, you have to check your op note. Was the repair lateral, meaning on the outside of the elbow, or medial, on the inside? And did the surgeon do a percutaneous procedure just going through the skin, or was it a fully open surgical debridement? And then, oh man, we have the legendary Tommy John surgery, super famous in the baseball world. In strict CPT language, this is an ulnar collateral ligament, or UCL, reconstruction, which is heavily covered by codes 24344 through 24346. When that vital bone-to-bone hinge on the inside of the elbow completely snaps, yeah, a simple stitch just isn't going to fix it. Let's look at how this builds into a complex surgical code. Instead of just stitching up that torn ligament, the surgeon actually harvests a completely healthy tendon from somewhere else in the patient's body, like the forearm or the hamstring. Then they drill these tiny holes directly into the elbow bones and literally weave that new tendon right through the bone like a figure 8 to completely rebuild the elbow's stability. It's wild. And because this inherently includes harvesting a graft, the code descriptor already includes all that extra work. Part 4. Fractures, where location is everything. This covers codes 24500 through 24685. Now, we're getting into the hard bone, where fracture codes are governed by one golden rule. Location is absolutely everything. Breaking the shaft, which is that long tubular middle section of the humerus, requires totally different codes and surgical approaches than breaking the supracondylar area. Supra just means above, and condyle refers to that knuckle-like joint surface. So a supracondylar fracture is right down at the very bottom of the humerus, hovering just above the elbow joint. To put it in perspective, a shaft fracture might be fixed with a long, thick metal rod hammered right down the center of the bone. Meanwhile, a supracondylar fracture is usually stabilized using thin, crisscrossing metal pins to hold all those delicate lower fragments together.
But wait, location isn't the only factor here. According to the general musculoskeletal guidelines, you also have to code based on the specific type of treatment the surgeon actually performed to fix the bone, regardless of the injury itself.
Let's clarify these real quick. A closed treatment means the fracture site is not surgically opened. The doctor might literally just manipulate the bone back into place from the outside and slap a cast on it. An open treatment, on the other hand, means the surgeon made an actual incision, pulled back the tissue, and physically exposed the bone to the outside world to fix it with plates and screws. And finally, percutaneous sits right there in the middle. The fracture isn't fully opened and visualized, but the surgeon drives pins or screws directly through the skin and across the fracture site using X-ray guidance.
Which actually brings us to a massive trick question. This one routinely trips up so many coders on their certification exams, so listen up. If a patient's diagnosis is a closed fracture, meaning the broken bone didn't actually pierce through the skin, does that automatically mean you have to use a closed treatment CPT code?
The answer is a resounding no. The CPT guidelines explicitly state that there is absolutely no coding correlation between the type of fracture and the type of treatment. A closed fracture could be so badly splintered or misaligned that the surgeon literally has no choice but to perform an open surgical treatment just to fix it. Always, always code based on what the surgeon actually did, the treatment, not just what the diagnosis is.
All right, moving to part 5, amputations, and our outro, covering codes 24900 through 24940.
We're capping off this CPT block with the most drastic extremity procedures in this section. Amputation codes change fundamentally based on the exact level of the cut. For instance, here we're looking at the transhumeral amputation. Trans means across, and humeral means the humerus. So this procedure involves severing the arm completely across the humerus bone, meaning the amputation happens entirely above the elbow level.
But beyond just the location of the cut, you really have to dive into that operative report to understand the phase of the procedure. Code 24900 is for a primary closure. This is that initial dramatic amputation surgery where the limb is actually removed. But code 24925 is an entirely different beast. This is a secondary closure or scar revision. You'd use this code when a patient comes back, maybe months or even years later, to have an older amputation stump cleaned up, perhaps because the bone is rubbing uncomfortably against their prosthetic. The codes change completely based on whether it's a first-time removal or a future revision. It's a huge difference.
To wrap up today's explainer, I really want you to internalize this quote. Location matters, and anatomical knowledge is your sharpest coding tool. In the 24000 series, knowing the difference between the shaft and the condyle, or between a ligament and a tendon, that's exactly what separates a novice coder from a master coder. Translating complex anatomy into plain, simple English is absolutely your best bet for accuracy.
And that brings us to the end of our journey through the upper arm and elbow. But before you go, ask yourself, if a surgeon uses KINs to fix a fracture without making a large incision, what kind of treatment is that? Keep that trick question in mind. Make sure to subscribe to Decode Healthcare with Harshal right now, because next time we are moving even further down the arm to tackle Part 8, the forearm and wrist, covering the entire 25,000 code series. You definitely won't want to miss how we decode the radius, the ulna, and those incredibly complex carpal bones. See you in the next explainer.